In this section of Chapter 8, we're going to move on from looking at LV output, dynamic changes in the left ventricular output as a marker of fluid responsiveness in the mechanically ventilated patient, and some of the caveats we talked about in the previous section. We're not going to move on to looking at dynamic left ventricular output and pulse pressure variation in the spontaneously breathing patient. In this patient population, to which I'll refer, are patients who are receiving absolutely no mechanical support at all. They're just breathing purely on their own. So we talked about the arterial pressure waveform in the mechanically ventilated patient, so let's talk about it in the spontaneously breathing patient now. The physiological picture is somewhat muddied when the patient breathes spontaneously without any form of mechanical ventilation. In the normal healthy patient, there tends to be this relationship is much less predictable in the spontaneously breathing patient than in the patient who's completely adapted with a mechanical ventilator. There tends to be an inspiratory decrease in systolic pressure. So remember, the mechanically ventilated patient who's passive with the ventilator, there tends to be an inspiratory increase. There's an inspiratory decrease in systolic pressure in the patient breathing on their own. And this is primarily a result of impaired left ventricular compliance. And the impaired left ventricular compliance is the result of diastolic ventricular interdependence. The decrease in intrathoracic pressure, however, can vary on a breath-to-breath basis and increased left ventricular afterload. As well, a lung inflation can compress the left ventricle from sort of behind in the cardiac fossa and impair its compliance. And then also recall that lung inflation, whether it's by mechanical ventilation or spontaneous ventilation, tends to preload the left ventricle by squeezing blood out of the pulmonary capacitance beds as a function of the increase in the transpulmonary pressure and the degree of West Zone 3 physiology. The more West Zone 3 physiology you have, the greater your pulmonary venous return. And again, if you've forgotten what West Zone 3 physiology is, I suggest you go back to Chapter 2. I think I talk about the West Zones, maybe Chapter 1 as well. So more on the arterial pressure waveform in the spontaneously breathing patient. On expiration, so there tends to be a D up, and again, this is highly variable. Some patients is minimal, some it's a little bit more. And the D up the increase in systolic pressure, the increase in pulse pressure tends to result from the transit of blood from the right ventricle, which had its preload increase during inspiration. So it's kind of the opposite of what we talked about with mechanical ventilation before. The increased preload distributed to the left ventricle tends to be tempered by decreasing lung volume. So as expiration proceeds, the D up is kind of tempered because the pulmonary vascular bed capacitance is increasing during expiration. So you kind of have two competing effects here. One is during expiration, there is more blood being discharged, or there had been more blood discharged into the pulmonary vascular bed as a result of the preceding inspiration for the RV. Remember, during inspiration and spontaneous ventilation, the RV is filling with blood, and therefore during inspiration, the RV is charging the pulmonary vascular bed with blood. And then during expiration, some of this excess blood is being seen later as a function of pulmonary transit time, but that's being tempered by the decreasing lung volume, which tends to increase the capacitance of the pulmonary vascular bed. The increasing intrathoracic pressure during expiration and decreasing right ventricular volume during expiration may facilitate LV unloading. That is improving or lowering left ventricular afterload and improving left ventricular compliance as the right ventricle shrinks during expiration. But in the normal heart, this tends to be minimal. Another important concept to consider here is something called the heart rate to respiratory rate ratio, which varies much more significantly in the spontaneously breathing patient. So when your respiratory rate is very high relative to your heart rate, or a low heart rate to respiratory ratio, the predictive power of pulse pressure variation falls down, and that's even true. I didn't really talk about this in the mechanically ventilated patient, but that's true even in patients who are fully passive with the ventilator. If the respiratory rate goes way up relative to their heart rate, then that D up, D down changes, because remember that the pulmonary transit time is 2 to 3 cardiac cycles regardless of your inspiratory time and your expiratory time. So in a normal heart rate to respiratory rate ratio, you typically see the D down 3 cardiac cycles later during expiration, solely as a function of that ratio. If your respiratory rate goes way up, then the cardiac cycle time, or the pulmonary transit time remains 2 to 3 cardiac cycles. You may be seeing what would be D down physiology occurring during inspiration, during expiration. It's hard to predict as your heart rate to respiratory rate ratio changes. So that's true even in the mechanically ventilated patient. It's even more true in patients who are breathing spontaneously. So this is the arterial pressure waveform in the spontaneously breathing patient. You can kind of see it's somewhat or almost the opposite of what it was in the mechanically ventilated patient. So again, we can define our apneic baseline. This is your systolic pressure at the end of an end expiratory pause, just prior to the onset of inspiration. And you could say this is your airway pressure here. This is your the baseline. So then here, this is your D down, the drop in your systolic pressure that occurs with inspiration. You have a drop in your pulse pressure as well. And then here, this is your maximal systolic pressure. This is your D up. And again, this is fairly variable, but your increase in your pulse pressure, or your maximal systolic pressure, which can occur during a spontaneous expiration, is probably more of a function of the increased right ventricular preload and increased right ventricular output that's occurring during inspiration after a short cardiac cycle time, or a short pulmonary transit time of 2 to 3 cardiac cycles. And this is really the physiology of pulsus paradoxus. So everyone has a somewhat normal pulsus, right? It's, a normal drop in your systolic pressure is less than 10 millimeters of mercury, but much more than that can suggest pathology, and that is what is the pulsus paradoxus physiology. So let's talk about the mechanism of an inspiratory D down in a patient who's spontaneously breathing. So again, here's your Guyton analyses for the right ventricle and left ventricle side by side. So the decrease in intrathoracic pressure that occurs with inspiration tends to distend the RV. So in this situation, unlike in mechanical ventilation where the RV function curve was moving rightward, again, remember this is the point that tethers the cardiac function curve with intrathoracic pressure. This point here, the x-intercept of the right ventricular cardiac function curve, tracks your changes in intrathoracic pressure. So as you inspire and you drop intrathoracic pressure, spontaneously I should say, inspire, your right ventricular cardiac function curve moves less leftwards in relation to your systemic venous return curve. And so your transmural pressure, or the distending pressure of the right atrium and the right ventricle, actually increases, and your cardiac output, or the operating portion of the Guyton analysis, increases, so your cardiac output goes up. Well, what does that do? Well, the increase in the distending pressure that you see during inspiration actually can impair the compliance of the left ventricle. So most people describe this as kind of a bowing of the septum into the left ventricle, but you don't necessarily even have to see a bowing. It's just, I think, as yet unknown mechanism whereby RV loading, even without a pronounced bowing of the septum, impairs or imparts a degraded or poor compliance on the left ventricle, and therefore for any given output of the left ventricle, the pressure is higher, and that is illustrated by a downward and to the right shift of the left ventricular function curve. So the drop in intrathoracic pressure, and again, this is more of a minimal effect in the normal heart, but the drop in intrathoracic pressure elevates your left ventricular afterload, which again shifts your cardiac function curve down and to the right. And as you inspire, lung volume can actually compress the left ventricle and further impair its compliance. Again, that's more of an effect on patients who are very hyperventilated. Like you can imagine you're asthmatic with status asthmaticus, or your COPDer who's hyperinflated. It tends to be less of an effect in patients with normal respiratory physiology. There's an augmentation of pulmonary venous flow with increasing lung volume that occurs. So that tends to retard the magnitude of D down. So again, you started, your operating point was here, and then during inspiration, because of a impaired LV compliance and an increased left ventricular afterload coupled with an increase in your pulmonary venous return as a fraction, or as a function of your fraction of West Zone 3 physiology, your D down is as such. Well, what about the mechanism of the expiratory D up? The D up is a variable effect that occurs during expiration. And as we saw in the previous slide, the preceding inspiration had augmented your right ventricular output and charged the pulmonary vascular capacitance with blood during inspiration. And that was what we saw here. So this is just a recapitulation of inspiration. The charged pulmonary vascular bed tends to maintain pulmonary venous return even as lung volume is being diminished during expiration. As the lung shrinks on expiration, the pulmonary vascular capacitance tends to increase, which tends to work against you in terms of augmenting pulmonary venous return. So if this pulmonary venous return curve here, again, this is your left ventricular function curve, left atrial pressure on the x-axis, right atrial pressure on the x-axis here, and blood flow on the y-axis. If this diminished, or this more translucent pulmonary venous return curve, this represents your end expiratory baseline pulmonary venous return curve. The expiratory increase in intrathoracic pressure then improves left ventricular compliance. So during expiration, there's a drop in your right ventricular preload, is dropped right ventricular preload reduction, and this tends to shrink your right ventricular cavity, improve your left ventricular compliance, and actually lower left ventricular afterload. So during expiration, there's a number of reasons why your left ventricular cardiac function curve is shifted up and to the left. But this effect may be highly variable. And the reason I sort of paused before on expiration was because you could see that the expiratory animation that I gave to you, this patient actually had a little bit of a forced expiration because their right ventricular function curve shifted to the right much more readily than if it was just a passive expiration. And the reason that I did that was to illustrate that the inspiration and expiration in the spontaneously breathing patient can be highly variable. So it's hard to predict how low their intrathoracic pressure is going with inspiration and how high their intrathoracic pressure goes with expiration. And again, that can have varying effects on their cardiovascular function and can make pulse pressure variation difficult to interpret. So again, here's the waveform in the spontaneously breathing patient. This is the apneic baseline. This is your D down. So what are the mechanisms of the D down in patients who are spontaneously breathing, and how could this degrade the specificity in a spontaneously breathing patient? Well, like we talked about in the previous section, during inspiration, there's a drop in your intrathoracic pressure, so there may be a direct transmission of that, so that could be part of the problem, part of the physiology of the D down during spontaneous inspiration. There could be an increased left ventricular afterload. Again, that tends to be a minimal effect in patients with normal cardiac function. The key mechanism here and the physiology of the quote-unquote normal pulsus is diminished left ventricular compliance, and that just occurs as the right ventricle is charged with blood. On inspiration, the compliance of the LV is impaired. And then also during inspiration, during spontaneous inspiration, there could be decreased pulmonary venous return. This latter number 4, decreased pulmonary venous return, tends to be less of an effect because, as we mentioned, as you inspire and you increase your transpulmonary pressure, you tend to squeeze blood out of the lungs into the pulmonary veins and towards the left ventricle. But in theory, this could be part of the physiology or augment the physiology in somebody who's profoundly hypovolemic. So the augmentation of D down during spontaneous inspiration. The presence of a right ventricular failure with or without the presence of excessive right ventricular afterload can exacerbate D down or delta down. This is in essence abnormal pulsus paradoxus physiology and clearly does not indicate fluid responsiveness. A good example of such physiology is cor pulmonale. Inspiration will augment venous return by recruiting abdominal venous capacitance, therefore improving the pressure head for driving blood back to the right heart and simultaneously reducing right atrial pressure. So you dramatically increase the gradient for blood return to the right heart. Elevated right ventricular afterload and compression of the left ventricle by hyperinflation of the lungs in cor pulmonale will only magnify this physiology. So let's consider, this is kind of one of the caveats for a D down in a spontaneously breathing patient. One consideration would be the clinical state cor pulmonale. So here they're side-by-side right ventricle and left ventricular cardiac function curves, assuming they've got a normal left ventricular cardiac function curve, but their right ventricle is highly afterloaded, say from hyperinflation, and maybe poorly contractile from years of high afterload. So the decrease in intrathoracic pressure during inspiration tends to distend the RV to an excessive degree. So you can see because the cardiac function curve is bent down and to the right, it already has a pretty high distending pressure. So if you looked at the right heart on echo here, you might see a distended RV. And then as you inspire, you're actually going to increase that distension, increase the transmural pressure to a much greater extent. And as I mentioned, I'm not illustrating it here, but pulmonary venous return curve will actually shift to the right somewhat as the diaphragm descends and recruits unstressed volume into stress volume, and improves or actually increases mean systemic filling pressure, increases the gradient for venous return. So this physiology will actually be even augmented by that. Nevertheless, in cor pulmonale with a spontaneous inspiration, the right ventricle will dilate. You may actually have worsening right ventricular afterload as lung function increases. And what that will do is during inspiration, you'll impair left ventricular compliance, shift the curve down into the right, and drop left ventricular output during inspiration from here to here, as we just saw. So the drop in intrathoracic pressure can elevate left ventricular afterload. And additionally, if the patient is really hyperinflated, kind of like the teardrop heart that you see in the chest x-ray, and they've got lower lobe gas trapping, that can compress the left ventricle and further impair its compliance and really impair left ventricular function. The augmentation of pulmonary venous flow with increased lung volume tends to retard the magnitude of D down. But again, you can see that clearly in a patient with cor pulmonale with a high inspiratory effort, they could artifactually cause a D down, and that does not mean that this patient is fluid responsive. So back to our home base, the arterial pressure waveform in the spontaneously breathing patient. So we talked a little bit about D down. So what about the potential D up, or the increase in pulse pressure variation that you can see in somebody who's spontaneously breathing? Again, this is a highly variable response, and it has probably to do with varying heart rate to respiratory rate ratios. But again, just for completeness sake, let's talk about potential mechanisms here. So again, as the intrathoracic pressure goes up, if the patient grunts or bears down a little on expiration, you may have a direct transmission of intrathoracic pressure. there's going to be a decreased afterload effect after that drop in intrathoracic pressure, which may facilitate some LV unloading. There'll be some improved LV compliance during expiration as the RV shrinks in size. And again, you have this kind of variable effect of pulmonary venous return during spontaneous ventilation, and that is during inspiration you tend to squeeze blood into the pulmonary veins, which tends to retard D down or diminish the amount of D down. But at the same time, during inspiration, the right heart is charging the pulmonary vascular bed with blood. Well, the converse is true during expiration. During expiration, the inspiratory increase in right ventricular output is now being reflected across the pulmonary vascular bed, but simultaneously, because lung volume is shrinking, the capacitance of the pulmonary beds is increasing, so that tends to diminish the D-up effect from pulmonary venous return. So let's talk a little bit about potential reasons for an augmentation of D-up. Expiratory D-up in this patient who's spontaneously breathing, where the augmentation, I'm referring to caveats or potential false positives here. The presence of left ventricular failure, with or without concomitant right ventricular failure, may result in a facilitation of an expiratory D-up, and we kind of talked about this in terms of the inspiratory D-up in mechanical ventilation in the previous section. Like during mechanical ventilation, this physiology will be magnified by high intrathoracic pressures, and therefore it's more likely to be seen in patients with forced expirations, where they're increasing their intrathoracic pressure to a high degree. So this is a patient with biventricular failure who clearly is volume not responsive. They're operating on the plateau portions of both ventricles, so giving them fluid would not be beneficial. But an increase in intrathoracic pressure during expiration lowers left ventricular afterload, which can augment its output of the failing heart. There's also a decrease in lung volume, which can improve LV compliance and further mimic that physiology. So you have an increase in left ventricular output during an increase in intrathoracic pressure that you get with expiration, especially if it's kind of a forced expiration. During expiration, to the degree that the right ventricular cavity shrinks as a result of the increase in intrathoracic pressure, left ventricular compliance will be improved by diastolic interdependence. And again, this will impair left ventricular output. So during expiration, as intrathoracic pressure increases, the right ventricular cavity will shrink as your transmural pressure shrinks, and that will improve left ventricular compliance and improve its output even more. Again, this is all occurring during a given expiration. The decrease in lung volume decreases pulmonary venous return to its end expiratory value, and this again tends to retard D-up. So as the lung volume shrinks, pulmonary venous return tends to seek its end expiratory value. So you have a diminution of pulmonary venous return, which tends to diminish the increase in left ventricular output that you get with the increasing intrathoracic pressure during spontaneous expiration. So again, you started with your operating point down here in this patient with biventricular failure, and the increase in intrathoracic pressure via favorable afterload effects on the left ventricle and favor diastolic effects with the right ventricle, you actually may see a bit of a D-up in this patient, which again would give you, in the spontaneously breathing patient on expiration, would give you pulse pressure variation, systolic pressure variation, and may fool you into thinking that this patient is volume responsive. So now that I've talked about all those possible caveats impairing the specificity of pulse pressure variation, systolic pressure variation, stroke volume variation, in patients who are spontaneously breathing. The best study of arterial pressure variation in spontaneously breathing patients demonstrated actually that its greatest problem was sensitivity, interestingly enough. What's important to realize that in that study, I believe this was, I forget what year it was Soubrier and colleagues, I think in intensive care medicine. They looked at pulse pressure variation in purely spontaneously breathing patients. There's no CPAP, no BiPAP, no nothing. They're just breathing on their own. These patients all had transthoracic echocardiograms to exclude right heart dysfunction. And they probably would have, I can't remember if they excluded left heart dysfunction as well, but a lot of those caveats that we just talked about in the previous slides that would degrade the specificity of pulse pressure variation as a marker of fluid responsiveness, those patients were excluded, so they would not have been picked up. And again, as we saw, it's really patients with right and left ventricular failure that may be more prone to having changes in pulse pressure that are not the result of fluid responsiveness. So those patients, the specificity in the study was actually quite good, but it may have been because they excluded the patients that would have degraded their specificity. The lack of sensitivity, the sensitivity was quite poor. I want to say it was in the 20% range, so there was a 70-something% false negative rate. The lack of sensitivity may have been the result of two key mechanisms. The first is inadequate inspiratory effort. So if we were trying to stress the right ventricular cardiac function curve as we did with mechanical inspiration, again, you want to have an intrathoracic pressure drop that is adequate enough to shift the cardiac function curve relative to systemic venous return and increase your cardiac output to induce this changes in D down and D up. And that may be more of the mechanism because later investigators have shown that pulse pressure variation sensitivity in spontaneously breathing patients is actually improved with the deep inspiratory maneuvers, not Mueller maneuvers, but deep inspiratory maneuvers improved the sensitivity much more. And another potential mechanism is the vascular water physiology that you get with great veins as intrathoracic pressure is decreased. And again, this is a physiology that you will not see in patients who are mechanically ventilated and passive with the ventilator because those patients only increase their intrathoracic pressure, so the cardiac function curve will shift rightwards. The right ventricular cardiac function curve will shift rightwards relative to the systemic venous return curve. But when you can shift the systemic venous return, when you can shift the right ventricular cardiac function curve leftward, as we will see with respect to the systemic venous return curve, you can get that plateau. You can hit that plateau region where you have a Starling resistor generation or vascular waterfall physiology, where you cannot increase cardiac right ventricular output anymore, and that may actually degrade the sensitivity. You may not be able to pick up patients who truly are volume responsive because their venous return is at its maximum as the great vessels collapse when they enter the thorax during a negative inspiratory effort. So how does that work? So again, it's this portion here that we're worried about. This is your intrathoracic pressure at the x-intercept. This is your CVP or right atrial pressure. And then this is your cardiac output. So in the hypovolemic patient, there's a shift to the left of the venous return curve. And notably, it also shifts down maximal venous return. So this patient clearly is volume responsive. Even this patient was volume responsive. This patient is clearly volume responsive. But what happens if this patient drops their intrathoracic pressure during a spontaneous inspiration? Well, they're going to hit this waterfall physiology or this Starling resistor physiology, and the great vessels are now going to start collapsing because of the low intrathoracic pressure. You can see this on an ultrasound. When a patient spontaneously inspires, the IVC collapses and then opens and collapses and opens, and that just leads to this plateauing effect of venous return. So this patient, they can breathe as hard as they want, really, and they're not going to be able to augment their right ventricular cardiac output because the right ventricle can only pump out what it's receiving, and it's being significantly limited in terms of what it can receive because of this vascular waterfall effect. So I think my animation just flubbed there a little bit, but what you can imagine is in this patient, if this patient's cardiac output is here, and then they inspire, well, then their cardiac output's only going from here to here. So that patient's not going to augment their cardiac output enough to contribute to a D up, and it's certainly not going to contribute to any D down physiology because the right ventricle cannot be distended as its venous return is impaired. And that was it for Part D. That was spontaneous ventilation, the pulse pressure variation that you get with a patient who's breathing completely on their own, and the physiology of it and some of the caveats that can come along that could degrade the specificity and sensitivity, and those namely being left and right heart failure, and then patients who are that degrades the specificity, and then the sensitivity is going to be degraded by patients who are so hypovolemic that you start to get vascular waterfall physiology, or collapsing effect of the veins as blood returns to the right heart, or in patients who simply do not generate enough of a negative intrathoracic pressure to truly stress the right ventricular cardiac function curve. So the following section, we're going to move on to a pulse pressure variation in the mechanically ventilated patient with spontaneous efforts. And I'm moving on to that section next, because now that you've mastered the physiology of the fully adapted patient with the ventilator, and then the physiology of the patient who's breathing completely on their own, you can start to appreciate that in a patient who is receiving mechanical breaths, yet that the patient is still generating inspiratory and expiratory efforts, pulse pressure variation in terms of D up and D down can be extremely variable, difficult to predict, and it probably explains why patients who are mechanically ventilated and generating inspiratory and expiratory efforts, the sensitivity and specificity of pulse pressure variation, stroke volume variation as a marker of fluid responsiveness is very poor. And actually, interestingly enough, in one study, I think it was in Critical Care Medicine, it's in my book, or it's not a book yet, but in the written portion, there is an interesting fact, and that was the pulse pressure variation and stroke volume variation actually performed less well than the pulmonary artery occlusion pressure. So we go through all these, I've gone through all this physiology to help explain why pulse pressure variation and stroke volume variation is really taking off, because it's seen as a replacement of static variables like the CVP. Some studies have shown that it's actually in these patient populations, that is the patients who are mechanically ventilated but triggering inspiratory and generating expiratory intrathoracic pressure change, the specificity and sensitivity is actually worse than some of the static parameters. So thanks for staying with me, and we'll move on to the next section very shortly.